I think we've reached the magical portion of the show this morning. We're going to talk about the magic of stem cells. And there's a lot of press out there over this. And you know, what happens? You get on an airplane these days, you sit down, you're bored, you look at the magazine in front of you, take it out, and you open page one, and there's this, you know, there's a spread where there's a completely arthritic person who got a magic injection and now they're magically perfect. So, you know, there's a lot out there, and we're going to kind of sift through where we are in 2016. What do we know? What do we not know? Is this truly magic, or is there some sleight of hand here? So we're going to go to the basics. Like, what is a stem cell? Is it really like a magic potion that we give to people? Stem cells are two basic things, right? They're pluripotent, meaning they have the ability to form any cell in the body. And then two, they can renew themselves. They can sustain themselves over the course of time. So that's the basic premise of our stem cells. And there are different kinds. Not all stem cells are created equal. We have embryonic stem cells, which are fetal stem cells. That's what we see out of the products of conception. So when you're first created and made, you have cells that really can become any cell in the body, and they are pluripotent in that sense. They can give rise to organs. You know, they're the start of the rise of any tissue in your body. And then we have adult stem cells, and those are a little different. Those are multipotent cells, meaning that they can only become a certain lineage of a cell. So they've already gone down the pathway that they're going to be musculoskeletal cells, they're going to be heart cells, they're going to be liver cells. So they can remake those certain cells, but only down the pathway that they've started. And these two guys up in the top won the Nobel Prize in 2012 because what they figured out is that you can take adult stem cells and actually make them embryonic stem cells. So you can take cells and de-differentiate them or make them embryonic stem cells so that they have the ability to make any cell around. And then lastly, we have amniotic-derived stem cells. And these are stem cells that you get from the amniotic fluid, from the placenta, from the cord blood. And those are kind of a hodgepodge of cells. You know, there are some embryonic stem cells in those, although they're very small. They're small in number, and there are more of these adult type stem cells in there. So we know the different kinds that we have. So what can we use? So embryonal stem cells is a really hot button topic. You know, there's a lot of ethical concerns. This is from fetal tissue, and it's from aborted fetal tissue. So, you know, what you see is there are political platforms as a part of, you know, who supports this sort of stem cell research. And so, you know, because of the ethical and legal concerns there, we're really prohibited from using those. And so that's the first problem, and that's the main problem. Then secondarily, you know, these are cells that can make any cell in the body. So if you take one of these cells and implant it into musculoskeletal tissue and it makes heart tissue, that's a problem, right? So that's oncogenic. That has the ability to form cancerous type growths. So those are the two main issues with embryonic stem cells. And if we go to these induced pluripotent cells, which are what the guys who won the Nobel Prize figured out, that you can actually make adult stem cells into these embryonal stem cells, it kind of takes away those ethical and legal concerns over, you know, using fetal tissue. However, you still have that carcinogenic, oncogenic potential that can arise out of using those cells. So really, you know, what we're left with are these adult cells. You know, they're your own tissue, so they're not rejected. There's no real immune response against them. There are no ethical or legal concerns there. The only issue is they can only differentiate into a certain lineage of tissue which they came from. They don't have the potential to be any type of tissue out there. And so they are really our most promising candidate to date. You know, they're safe. Again, they come from your own body, your own tissue. They're well studied. They're what we've studied the most and looked at the most. And they're readily available in your body. They came from bone marrow, from your fat, from the lining of the joint in synovial membranes. And the covering of the bone. And then what we know is that the stem cells from those tissues, if we look at, they've been demonstrated, they can form bone, they can form tendon, they can form cartilage-like material. So they do the things that we want them to do. So how do we apply them? So what do? So we harvest them from the body, and then we deliver them back in. But there's an interim step there. So you can take the stem cells, and this step's really kind of mandated or regulated by the FDA. We can take those cells, and we can take a kind of a large quantity or aspirate from your body, and we can concentrate them down into a smaller injection where there are many, many stem cells in there. What we're not allowed to do is to take those and amplify them. Amplify them up and grow them into a culture. We're not allowed to expand them. The FDA does not allow for any significant manipulation of the tissue outside the body. So once we have the cells and once we're ready to deliver them, that could be done in two ways. And the first is simple. It's cell therapy, which means we take the cells out and we inject them into the damaged tissue. And this has the ability to kind of help heal that tissue directly. What it can't do is replace large defects. So if we have a large defect in a tissue, we haven't been able to figure that out through cell therapy, how to improve that. We can't replace an organ with that. And the second way you can deliver stem cells is with tissue engineering, which is a little bit more of a sophisticated technique. There's a lot of promise to it. It's basically seeding stem cells on a three-dimensional matrix, and this would be really to replace a larger piece of tissue kind of in block, and in using it to I would say replace a tissue that we've lost that's not on a small cellular level. The problem with this, and we've gone through animal studies and looked at trying to do this, the problem is in trying to replace bigger tissue, we need a lot of vascularity, and these constructs, we really haven't been able to figure out how to get the vascularity there. So there are really no clinical applications to that yet. We haven't really figured out how to make that work yet. So our best site is from the bone marrow, and really from the wing of your pelvis is where we think we have the best concentration of viable stem cells. And we're going to see a little video of this is the procedure in its entirety. So we make a little nick in the back of the ilium of your pelvis, and we put a needle down and aspirate that marrow from the pelvis. And then what we do is move it, change positions just so we get a better quality and a better area of fill of the blood. And then we'll take that away, and you'll see it's a really small poke hole. We pull it out, and it's a little poke hole that we put a dressing over, and that's kind of the procedure in its entirety. And what we're able to do is concentrate these now. We're able to take and separate the blood components away. So we're able to take out the red blood cells, take out the inflammatory cells, take out the platelet cells, and be left with these stem cells. And so what we do is put it in one of these fancy machines. It's a centrifuge that what it does is separates all these components for us. So we're able to spin this, separate out the components, take out those marrow stem cells, and have them be available for injection into tissue. So it's a pretty quick and simple process. So how do they work? What do the stem cells do? Right? So there are three ways that the stem cells work. So one, when it's actually injected into the damaged tissue, those cells can actually become that tissue. So it can actually be a cartilage cell or a tendon cell or a ligament cell itself. It has the ability to turn in that. And secondarily, it can also signal other cells to come in and repair the tissue. So it works, to locally grab other cells to come in and heal the tissue. And then third, and maybe more important for some of our applications and where we see promising or positive results, is that it is a really powerful eliminator of the inflammatory response pathway. So, so how do we use them in orthopedics? And I think over the course of time, orthopedics has changed somewhat. We used to always be very bone-centric, and so orthopedics was always about treating the bone. And now, over the course of time, as we've gotten more active, we've become a more active population over the generations. Our treatments are more about what gets our bones to move and what keeps us active, which are things like your cartilage, your tendons, your ligaments, your muscles. So we've come more to treat these things. Now the problem with these tissues is they oftentimes have a poor blood supply. So the hallmark of chronic problems are these kind of chronic small injuries that don't have a great blood supply and can't heal themselves on their own. And so when we try to treat these injuries, we don't have great methods to treat them. We have methods that treat the symptoms, but not always the underlying cause or root of the problem. So things like chronic tendon inflammation, which is tendinosis, defects in our cartilage, even areas of the bone, avascular necrosis, where we've lost blood supply and it can crumble around it. Those things we haven't had great overall treatment success for. So there are a few things that we've seen over the course of time that has been successfully treated in patients, and those are things more related to the bone. So we have good evidence that when we have breaks that just won't heal for whatever reason, we've seen good studies where stem cells have been injected to these breaks and will heal that area of a non-union. And even in some areas of small bone defects, of open up and grafting these with stem cells, there's been very good results of that. As you'll see on the bottom, and there's an area of avascular necrosis, which is, if we look here, there's an area where the bone has died. And so what we're able to do is treat that with making little vascular channels into the bone. And that over the course of time hasn't had very good results, but we've seen some improvement with adding stem cells into that area. And then finally, we've seen some enhancements in spine fusions, trying to create bone around spinal fusions, and we've seen with stem cells that has been significantly better. So the other things that we have that we want to treat that we don't have great treatment applications for, and we'd like to enhance, are the other tissues. So, namely tendon. We know tendon to tendon healing and tendon to bone healing is not as good as bone to bone healing. And again, it's really, there's not as good of vascularity in tendon. So there's been a lot of animal studies and experimental evidence trying to enhance the healing of tendon healing, or even to treat chronic inflammation in the tendon. And that looks really promising out of the animal data, but the problem, it's been somewhat inconsistent. Like what's the right doses that you use, what's the right construct? The results have been somewhat inconsistent. So the problem is there's a hodgepodge of animal data out there that's fairly inconsistent. So there's really no clinical application of that yet. So we haven't really gotten off the ground, from these animal models and animal studies yet with tendon healing. So cartilage is important. Cartilage is really avascular. There's really not blood supply in the cartilage. The cartilage is really maintained by the fluid in your joint. There are nutrients in the fluid in your joint that maintain the health of your cartilage. And so when the cartilage gets damaged, it really doesn't have the capacity of its own blood supply to heal itself. So what we really worry about is that progressive damage over time ends in arthritis, and it ends in a lot of dysfunction. So our standard treatments are these, where you see on the bottom we have a cartilage defect. And what we try to do is mimic those stem cells. We try to stimulate the marrow stem cells by making holes in the bone. And this is our conventional microfracture treatment, where we try to get it to bleed and take your body's stem cells to make cartilage. And then we also do cartilage transplants. We either take cartilage from other areas, our own tissue, and try to fill in those defects. Some of the problem with those is it does make cartilage, but oftentimes that cartilage is not the normal cartilage in our body. It's more of a fibrous cartilage. So we can make it, but it's not a perfect cartilage, and there are some issues with that. So there's been a lot of animal studies that have gone on, and those have been very successful and promising. And so, cartilage has actually made its way from animal studies into clinical treatment now. So we've had some early clinical studies. And what we've really tried to do is take this from marrow stimulation or injection of cells to actually making scaffoldings that you can post the stem cells on, and that can actually fill the defect physically and then integrate into cartilage cells. So those are promising. Those are promising studies that are out there, but they're somewhat limited. They're in small numbers. We don't have long-term follow-up on it. So we're getting closer to enhancing what we do in cartilage repair, but we're not quite there. And then finally, this is what everybody wants. Everybody wants a magical injection to solve their arthritis. And that's where the biggest buzz is here on stem cells. And so there are numerous studies out there clinically where we've looked at patients, and they're promising. They show improvement for injecting stem cells for arthritis. And I think they show very modest improvement when you actually look at the status of the cartilage. When we look back, there's a modest improvement about the quality of the cartilage is there when you look there a year later. There are no, there are no studies that show when you inject stem cells into a knee or into a joint that it makes the cartilage new again. We don't see anything where you inject it to arthritic knee and it's no longer arthritic. What we do see is a lot of clinical improvement when you look at injecting stem cells versus injecting cortisone or injecting our lubricants for arthritis. This really seems to improve patients for a much longer period of time. And I think that goes back to the fact that stem cells are a very, very potent anti-inflammatory. They really suppress a lot of the inflammatory pathways. So there's a lot of promise in this. We're just at the tip of the iceberg here. The problem is that they've all been pretty small in the studies that we've seen. It's small numbers, it's short-term follow-up. We need bigger studies. We need more people. We need people where we inject saline in one and stem cells in the other. Who gets better? Who's better for what period of time? What does their cartilage look like? So we need to prove the stuff that we've seen early on. So there's a lot of promise here. We're just not quite there. So there's a problem with these too, and if you look, there's a lot of press out there of what stem cells can do for you. But this is you got to have there's really a problem here. This could be today's snake oil. There's a lot of things being promised for a lot of money, and that people are doing without a lot of without a lot of study behind it. You can find anything out there on the web. You can find anything. You can find the $100 stem cell bra. So be careful with what's out there. So I think the bottom line is we're not there yet. We haven't figured it out yet. There's a lot of promise. There's a lot of improvement. We haven't quite figured out how to take an arthritic joint and make it new again. With stem cells, we're figuring out that it may improve the way that joint functions, but we're not at the point where we can make it a new again.